Jeelani. Dr. Hamad is an acting consultant of nephrology in Sultan Qaboos Hospital in Salalah. Today is an interesting topic about polycystic kidney disease. In fact, previously in the past, polycystic kidney disease had no specific treatment at all. It was just control of hypertension, watch for hematuria, and then conservative treatment until renal replacement therapy comes. So now we are having some options for polycystic kidney disease, and this will be our topic today. Dr. Hamad will talk about exploring aquaretics as a strategic approach to treat autosomal dominant polycystic kidney disease. Dr. Hamad, please proceed. Thank you.
Bismillahirrahmanirrahim. It's a great pleasure to be the part of OSNT, and I thank all my seniors and colleagues who have given me an opportunity this evening to present this topic today. Aquaretics have totally changed the paradigm of the treatment of ADPKD patients. Till now, as Dr. Fadi rightly mentioned it, we had only conservative measures like control of hypertension, proteinuria, and hematuria and cyst complications thereafter, and just trying to slow the progression to the end-stage renal disease, and ultimately renal replacement therapy in the form of transplant or any modality of dialysis. But since the introduction of aquaretics, the paradigm of the treatment has completely shifted. So I'll be discussing the topic today in front of this August gathering. To begin with, I have no disclosures. So my outline will be, I'll give a few slides regarding the ADPKD, what is autosomal dominant polycystic kidney disease, a little bit of historical perspective, and the role of vasopressin in driving the disease process, how aquaretics or vasopressin antagonists help to halt the process to some extent, and can we prescribe these molecules to all the patients who have ADPKD, and how to prescribe and how to monitor these patients once they are started on this therapy. Probably the first documented case of ADPKD was the Polish king Stephen Petre, who died after the acute illness of 9 days with intracerebral hemorrhage. Subsequently, the autopsy showed that he had big kidneys, that time defined as kidneys like those of a bull. And on autopsy, they saw that kidneys have multiple cysts and they are enlarged. Subsequently, in 1888, the term polycystic kidney disease was coined by the Flex Legeres. And down the path in mid-90s, two important genes, PKD1 and PKD2, were identified to be the culprit genes which drive the disease process. This led to the vasopressin antagonists in animal studies in 2000 and 2003, and ultimately leading to two important successful human trials, the Tempo 3 and 4 in 2012 and Reprise in 2017. Which was followed by this approval of tolvaptan in European and Canadian market in 2015, and finally the approval by FDA in 2018. So a word about what is autosomal polycystic kidney disease. We know the kidneys are replaced by multiple cysts which arise from the vasopressin sensitive part of the nephron, mostly distal convoluted tubule and collecting duct. This disease is found as an autosomal dominant inheritance. That is, if the parents have the disease, there is 50% of chance the sibling will get the disease. It affects both the sexes equally and occurs across all ethnicities. It is seen in the literature that it is responsible for about 5% of all end-stage renal disease patients and the fourth most important leading cause of end-stage renal disease. It is seen in incidence in literature is around 1 in 500 to 1 in 1,000 live births that the patients can have ADPKD. And it's the most common form of monogenic inheritable kidney disease. So, as I said, that renal parenchyma is replaced by small cysts which are present right from the birth, but ultimately once the cysts progress, it becomes easy by imaging techniques to pick those cysts. The cysts grow in size and number and ultimately replacing the normal renal parenchyma, thereby leading to the impairment of renal function and finally end-stage renal disease. Depending upon the mutation, whether it is a PKD1, which is mostly found in around 80% of patients, progression to end-stage renal disease occurs by late 50s or early 60s, while the PKD2, which is responsible for 10 to 15% of the patients, lead to end-stage renal failure maybe a decade or 2 decades later than the PKD1 mutation. So studies have documented that rather than assessing the GFR loss, the increase in the volume of kidney, that is total kidney volume adjusted for age, is a good prognostic marker to assess the disease severity and progression in these patients. It is important to know that it is actually a ciliopathy. That is, there are primary cilia. This is the tubular epithelial cell. This is the urinary segment side. This is the basement membrane. There are primary cilia which are protruding into the tubular lumen. There are two important proteins. We can see this green one. This is a polycystin one, and the blue one, the polycystin 2. These are governed by the PKD1 gene and PKD2. So what actually happens, there is because of the loss of mutation, the total quantity of this polycystin decreases in these primary cilia. The primary cilia are important to maintain the polarity and cellular differentiation of the tubules. These cilia act as mechanoreceptors, leading to the entry of calcium in these cells. So once there is decrease in the amount of polycystin 1 and polycystin 2, all these normal functions of the polycystin mediated functions get impaired in these patients. This slide is very important to understand, and this will subsequently explain us how the tolvaptans are acting on these patients. We can see here the blue color shows the pathways which are stimulated in these patients, and the brown color shows the pathways which are reduced in these patients. So once there is a mutation in polycystin 1 or polycystin 2, what happens is there is a lot of entry of calcium from extracellular to intracellular membrane. This is a tubular cell. For example, if we take distal convoluted tubule or collecting duct, which is having vasopressin receptor, this is the cell. And there is also release of calcium from endoplasmic reticulum. Finally, this increased amount of calcium in the cellular compartment stimulates adenyl cyclase, which leads to formation of a lot of cyclical AMP in the intracellular compartment. Cyclic AMP is increased intracellularly also by the adenylase cyclase. The vasopressin 2 receptor pathway is also upregulated, so ultimately leading to the increased amount of cyclic AMP intracellularly. Once there is increased level of cyclic AMP, it stimulates protein kinase A. Protein kinase A, then down the path has two important pathways. One is through mTOR and cyclin-dependent kinase leads to the formation of growth factors and pro-inflammatory cytokines, which are ultimately responsible for the proliferation of the cysts and multiplication of the cysts. It also stimulates the chloride secreting channels at the luminal side, so a lot of fluid is secreted in these tubules, leading to ultimately the accumulation of fluid and proliferation of the cysts. To make it more simple, if we can see that vasopressin, once it binds to the V2 receptor, this is tubular epithelial cell. This is the vasopressin receptor. This is the vasopressin molecule. Once it binds, it increases cyclic AMP, leads to secretion of a lot of fluid and proliferation of the cellular wall. So what was found in the study that if we block this receptor by competitively giving a tolvaptan, which are antagonists of the vasopressin 2 receptor, we can decrease the levels of cyclical AMP intracellularly, which ultimately will decrease the proliferation in these cells and decrease the fluid secretions, the basic pathogenesis which drive the cyst formation in these tubules. Let's dig some literature suggesting the role of tolvaptan in these patients. These studies, many other studies, and these studies have shown that if we switch off the genes for vasopressin receptor or the release of vasopressin, or we pharmacologically block the vasopressin receptor with tolvaptans, ultimately the severity and the progression of ADPKD can be halted to some extent. So after the successful pre-human and animal studies, it was this landmark trial which was published in NEJM in 2012, the first randomized controlled trial which showed the beneficial effect of tolvaptan in these patients. And this was a multi-center trial done across 15 countries involving 129 sites, a phase 3 double-blind placebo-controlled trial which ran over 3 years period, having more than 1,400 patients from the age group of 18 to 50 years. The inclusion criteria was those patients who have ADPKD and the total kidney volume at the entry should have been 750 ml or more, and the creatinine clearance of more than 60 ml. They were randomized in 2:1 ratio to either receive tolvaptan or the placebo, matched placebo. So what they saw, the primary outcome was the annual rate of change of total kidney volume. And the sequential secondary outcome and other outcomes were rate of kidney function decline, the worsening of kidney function like increase in creatinine by 25%, acute pain events, hypertension and albuminuria. So what they found that this blue depicts the tolvaptan, this red depicts the placebo. So the y-axis is showing the change in total kidney volume over the duration of 3 years. That's 1 year, 2 year, and 3 year. They took the MRI scans at annually. They saw that tolvaptan decreased the progression in total kidney volume by around 2.8% as compared to placebo, which was about 5.5%. So they showed that the tolvaptan is a beneficial here in decreasing this worsening in the total kidney volume over the period of 3 years. This forest plot shows in the if patients, according to the subgroup analysis, whether less than 35, more than 35, they had a hypertension at baseline or not, creatinine clearance of more than 80 or less than 80, or total kidney volume above 1500 or below 1500, tolvaptan was beneficial across all the groups as compared to the placebo. Similarly, the secondary outcomes like decline in kidney function was shown that tolvaptan is doing better as compared to placebo, and a decline in the GFR was around 2.6 ml per year as compared to placebo 3.8. So here also there was clearly shown that tolvaptan is doing better as compared to placebo in this patient. Similarly, if we do the subgroup analysis, tolvaptan had shown the beneficial effects as compared to the placebo in all the patients. The other secondary outcome important is this acute pain event. Acute pain event means that patient who have hematuria, cyst infections, increase in the cyst size may lead to acute pain. This was seen that tolvaptan can decrease all those episodes as compared to the placebo, indirectly proving that the tolvaptan is halting the process of cyst increase, maybe initially by decreasing the fluid secretion, and on long term probably by decreasing the proliferation of cysts. So this study clearly showed that the tolvaptan is doing better as compared to placebo in the patients who had ADPKD. Coming to the adverse effects were comparable between the two groups, that is placebo and tolvaptan. But the group which received tolvaptan had the adverse effects mostly related to aquarius, like they had more thirst, polyuria, plaqueuria, nocturia, while the patients who were on placebo had the side effects related actually to the disease process, the worsening of disease process, like pain, acute pain, chronic pain, hematuria, cyst infections. It was also seen that the patients on tolvaptan had more chances of having hypernatremia. Around 4% of patients had hypernatremia as compared to the placebo, 1.4%. Similarly, the frequency of gout in tolvaptan group was around 3% as compared to the 1.4% in the placebo. However, no episode of gout was serious enough to stop the medication during the trial period. 2 patients had a severe transaminitis defined as ALT elevation of more than 3 upper normal limit, had to stop the tolvaptan. Although rise of ALT around 2.5 times the upper normal limit was seen in this tolvaptan as compared to the placebo. Aquarius related adverse effect led to the discontinuation of tolvaptan in 8% of the patients, mostly in the initial months. So this study clearly showed the benefits of tolvaptan over the placebo in a specified group of the patients who had ADPKD. It was subsequently extended 2 years as an open label extension trial to see whether if we extend the tolvaptan, whether the benefits of tolvaptan will be continued or not. So what they saw that there is sustained disease-modifying effect of tolvaptan after the 2 years of Tempo 3 trial, and the safety profile was comparable to that of Tempo 3 trial. So these two studies took the patients who had a maintained EGFR like more than 60. What about the patients who have advanced renal disease like stage 3 and stage 4? So scientists came up with this study, which was published in 2017 in NEJM, to replicate the evidence of preserved renal function in ADPKD, short form representing the REPRISE trial. So this trial was done in around 1,300 patients. Those who were having the age group of 18 to 55 with EGFR of 25 and 65 were taken, and the patients 56 to 65 with EGFR of 25 to 44 were included in this study. This study had around 8 weeks of pre-randomization protocol divided into 2 weeks of screening, followed by the single run in placebo of 1 week, and tolvaptan titration phase of around 2 weeks, where the dose of tolvaptan was increased from 45-15 milligrams to 60-30 and ultimately 90-30. Sorry. Following that, there was a run-in period of tolvaptan, and then in the double-blind fashion compared to the placebo. So study was carried for 12 months. And the primary outcome was change in EGFR from baseline to follow-up after 12 months. So what they saw that tolvaptan is doing far superior as compared to the placebo in these patients. As we can see, the decline in EGFR was far less in tolvaptan group as compared to placebo, and tolvaptan had a 35% reduction in the decline in kidney function over the period of 12 months. Similarly, this can be represented in this slope. We can clearly see that the blue slope is of tolvaptan. Blue slope is of tolvaptan and the red of placebo. The slope of placebo is more steep as compared to the tolvaptan. On subgroup analysis, tolvaptan had beneficial effects as compared to the placebo in all the patients across all stages of CKD, like CKD 2, 3A, 3B, and 4, whether baseline EGFR was less than 45 or more than 45, among whites and non-whites, and males and females. Since these trials were short duration trials and the disease of ADPKD is a chronic disease, and ultimately patient has to take either this tolvaptan lifelong or till he progresses to renal replacement therapy. So what was done to see to extrapolate the beneficial effects of the tolvaptan, depending upon the EGFR loss across the tolvaptan and placebo, the data showed that if we start tolvaptan at the higher EGFR, for example, if we start tolvaptan at the EGFR of 90, we can gain as much as around 6.8 to 7.3 years before patient progresses to end-stage renal disease. Similarly, there was beneficial effect of around 1.5 to 2.3 years if tolvaptan would have been started at the EGFR of as low as 30. So all this data clearly shows that tolvaptan was doing far superior across all age groups, all the ethnicities, across all the stages of CKD as compared to the placebo in halting the progression of the disease. So, is this tolvaptan can be given to all the patients? The answer is simply a no. So, how should we assess which the patient is fit for this therapy, and how should we progress whether the patient is qualifying for this therapy? So, first step is to confirm the diagnosis of ADPKD. Second is that we should confirm that this disease is rapidly progressing. After that, we should ensure the implementation of all basic renal protective measures like control of hypertension, control of proteinuria, dietary modifications, lifestyle modifications, and give the balanced information to the patient about the beneficial and harmful effect of tolvaptan across the various stages of the CKD. And it is very important to exclude the patients who may not get benefited from this molecule. So it is to be excluded prior initiation of the therapy. We should educate the patient related to the aquarius and its expected consequences. And ultimately, we can start with the doses mostly seen in the studies like 45 in the morning and 15 milligrams in the afternoon, and titrate dose accordingly, monitor the related complication, and evaluate and manage the complications related to this therapy. So I'll try to touch all these slides briefly so that we can get a better idea of this therapy, how we should start and how we should monitor. First step is we should confirm the diagnosis of ADPKD. History is always a paramount important in the medical profession. Somebody comes to my clinic with the history that his primary first degree relatives had ADPKD at the late 50s, and his ultrasound is showing bulky kidneys with lot of cysts. I think I don't need any other thing to confirm the ADPKD in such patients. So imaging has definitely been the cornerstone in diagnosis of these patients. This is the modified USG criteria showing that patients can be diagnosed with across the various age groups if they qualify for the number of cysts as per shown in the criteria with 100% positive predictivity and sensitivity of more than 80% up to 100% across the age group, various age groups. Patients who have equivocal ultrasound findings, or especially those who are less than 40 years, or have PKD2 mutation. We know PKD2 is a slowly progressive disease as compared to the PKD1. In those patients, ultrasound may not be as good sensitive, having good sensitivity as compared to MRI. So in these patients, we can use MRI, which if MRI picks the findings like more than 10 cysts in each kidneys, bilaterally enlarged bulky kidneys, probably we are certain that it is ADPKD. And the sensitivity and positive predictivity has been shown to be around close to 100% with the cysts 10 and above in each kidney with the MRI. And if the MRI shows the cysts less than 5, it almost excludes the disease in these patients. In doubtful cases, we can always go for the genetic testing and confirm our diagnosis prior to the initiation of the therapy. The genetic testing can be also beneficial in the cases where we have to prognosticate the disease, to give the family planning choices, or in the patients who have atypical presentation like early presentation, there is no family history. So the paramount important of these three slides is that firstly we should confirm the diagnosis of ADPKD before progressing to the next step. So the second step is we have to assess whether disease is a rapid progressing or a not rapid progressing, because the studies have shown that the tolvaptan is beneficial in the patients, those who have rapid progression of ADPKD. So various criteria are there in the literature, but most consensus are around the pro-PKD score, which involves the genetic testing, which is not always available, and other parameters like sex, hypertension before 35 years, urological manifestations before 35 years like flank hematuria, cyst infection, flank pain. So they have given a point score for each of these variables. If cumulative score is 7 and above, probably we are dealing with a patient who has ADPKD, and there is high chance of that he will progress to end-stage renal disease in his late 40s or early 50s. If the score is 4 to 6, there is an intermediate chance that he will progress to end-stage renal disease in his late 50s or early 60s. One point I would like to mention that it's not necessary we get all the parameters done to assess the severity in the pro-PKD score. If we have a patient, for example, if I have a patient who is less than 35 years, has a hypertension and urological manifestation, probably I will not go for a genetic testing. I will straightway look for other inclusion criteria, whether I can start tolvaptan, and mostly answer will be yes in such cases. So it is important to look for the individual score also rather than the cumulative score. This is the second criteria to classify whether disease is a rapid progressive or not. Mayo Clinic has done excellent work. If I have to put my money to diagnose the patient with ADPKD, probably this is the only test I will require in my clinic to see the patient is having rapid progressing ADPKD or not. This was done to assess, x-axis is showing height adjusted total kidney volume, you can see, and y-axis is showing height adjusted total kidney volume, and x-axis is showing the age. So once we do the MRI scan, we can simply see the total volume on the MRI, which can be calculated by using ellipsoid equations, or more specifically by the volumetric analysis. So we can simply say what is the total volume of kidney and put the dot on the graph and assess whether this disease is a rapidly progressive or not. They classified the typical disease. Typical disease means that patients who have symmetric distribution of kidney cysts, involvement of both the kidneys, and huge and bulky kidneys, which is mostly the case in 90% of the patients, while 5% of patients can have atypical presentation, and this Mayo classification cannot be applied for those. In those cases, we have to look for other parameters. So if somebody lands in the graph across the group C or E and he has rapidly progressive disease, I don't need to go for any other investigation to begin with tolvaptan in such patients. This is an algorithm suggested by European Renal Association and World Group of Kidney Disease, that if somebody who has EGFR of more than 25, age is less than 55, and he has ADPKD, and age adjusted EGFR is below the particular limit. We know that with the age there is decline in the renal function. So if somebody has EGFR less than specified for his or her age, probably he has a rapidly progressive disease, and we can supplement this data if there is a reliable EGFR decline of more than 3 ml per minute per year over a period of 4 years or more. Or we can just take the Mayo classification for this total kidney volume. So all these parameters are going to help us whether the patient is having a rapidly progressive kidney disease or not. And in those who have rapidly progressive disease, there is a strong indication we should go for tolvaptan therapy in addition to the other conservative measures. So to put all this thing in the table, we can see that we have to look for the age-adjusted EGFR, look for the Mayo classification of the cysts 1C and more, and simply sometimes an ultrasound finding, like somebody has a huge and bulky kidney of more than 16.5 centimeters and of the age less than 50 years. Probably he has a rapidly progressive disease. If genetic testing is available, we can go for pro-PKD scoring, and score of more than 6 will qualify him for the rapidly progressive disease. Definitely clinical parameters should be taken into consideration, like urological symptoms, like macrohematuria, cyst hemorrhage, flank pain, cyst infection before the age of 35 years, early onset hypertension, family history, especially first degree relatives who have progressed rapidly to end-stage renal disease in their fifth decade. These are all clues which suggest us that this patient is having a rapidly progressive disease and is a suitable candidate for initiation of tolvaptan therapy. So we are done with the second step. Then how to start with the dose? Most studies have shown that we should begin with the dose of 45 milligrams, preferably taken in the empty stomach, and the afternoon dose should be taken around 6 to 8 hours later, not too late to avoid the nocturia. Dose can be escalated either on weekly basis to 60 to 30, and then ultimately to 90 to 30, which is done in most randomized trials. Weekly basis or monthly basis, both is acceptable across the studies. So once we have achieved the optimum dose, we can continue that dose, but before initiation of this therapy, we have to look for some important things, like patient should not have hypersensitivity with this drug. The baseline liver enzymes should be okay. He should not be volume depleted. There should be no uncorrected dyselectrolytemia. He should be able to perceive and respond to the thirst. She should not be pregnant or should not be feeding breastfeeding. Patient should not be anuric, and there should be no partial obstruction to the urinary flow. One more important thing I would like to stress, we have to look for the other drugs also which patient may be concomitantly taking, which may interact with the tolvaptan, because tolvaptan is metabolized by CYP3A4 enzyme, and there is possibility that he may have a lot of interactions which may increase the dose of drug in the blood, or may, if there is some enzyme inducer which may decrease the efficacy of drug by rapidly metabolizing the drugs. This is a very congested diagram. I'd like to mention that the red color shows those drugs which are strong inhibitors or strong inducers, and the orange color shows the drugs which are having a moderate inhibitor or inducer action on CYP3 enzyme. So we should try to see the other drugs which the patient is taking, which may interact with the tolvaptan once the therapy is being finalized. As we know, the most important, I should not say the side effect, this is the consequences of the treatment. Once we are blocking the V2 receptor, the patient is going to have polyuria, polydipsia, and other manifestation like nocturia, plaqueuria, and thirst. The other important side effect with this therapy, which has been seen in the studies, is transaminase. I'll describe a few slides regarding these side effects and how we should manage these side effects in these patients. To begin with, we can see the study was a retrospective analysis done in large Canadian cohort. They saw that around more than 300 patients who were actually of this cohort were eligible for receiving a tolvaptan therapy, but only 30% of the patients could actually receive their therapy at the end. Knowing that the tolvaptan has changed the paradigm, there is a paradigm shift because of tolvaptan in these patients, but only 30% will receive the drug. So the barriers should be looked into keenly and try to solve the barriers for this giving the tolvaptan therapy. We should come over the barriers so the patient receives the optimal benefit of these drugs. Likely in this study was seen that around more than 50% of the patients had difficulty in adjusting the lifestyle after they were initiated on tolvaptan therapy. Around 12% of the patients were not taking the drug because of advanced age. Around 6% of patients had issues with family planning. The other important thing I would like to mention is the job and occupation is very important before considering somebody putting on the tolvaptan therapy. For example, around 41% of the patients were not able to take tolvaptan because they were not in a circumstances to have or were allowed to take the frequent breaks during the treatment therapy. So this is a big number which probably missed the benefit of the therapy in this cohort. So once we are going to start somebody on tolvaptan, we should discuss the side effects with the patient and provide a written patient information prior to initiation of tolvaptan. Start tolvaptan on the weekend or when they are not at work, so that it helps them to adjust the aquaretic response. And the timing of second dose, which is usually 6 to 8 hours from the morning dose, should not be too late in the afternoon. This may help to prevent some symptoms related to nocturia. This will give them enough sleep and it will ultimately be having more compliance to the treatment. We should definitely advise the patient for sick day guidance, like withholding the tolvaptan during the period of acute illness, like going for surgery. We can hold tolvaptan at least 48 hours before the surgery and initiate the tolvaptan therapy once he is taking orally adequately and can maintain and perceive the thirst, like we do for AC inhibitors and ARBs. There is a notion that we can reduce the second dose if the patient is having unbearable symptoms of nocturia, but on the long-term basis, this should not be favored because this will ultimately decrease the efficacy of these medicines in these patients. We should ask the patients to decrease the solute load, like decrease in the sodium and moderation in the protein intake. This will not only improve their blood pressure and antiproteinuric measures, this will ultimately decrease the natriuresis because less fluids is to be excreted. So overall, the natriuresis may come down. Some studies have shown that if we combine tolvaptan with metformin or we combine tolvaptan with long-acting octreotrides, probably the nocturia or total amount of urine which they pass over 24 hours will be less. So the patient compliance may be improved. Drug holidays should be definitely discussed with the patient, especially if they are going for long travel and if there is a possibility of limited access to the water. So we are done with the aquarius part of this side effect, how to troubleshoot this side effect. All the patients should be monitored initially monthly for 18 months because most of the side effects are confronted in the first couple of months. And it is important to monitor monthly for first 18 months. Thereafter, we can monitor every 3 months. So what should we do? What labs we should do? We should look for sodium, potassium, uric acid, LFT, RFT, and for example, if somebody has hypernatremia, sodium levels are going up, who is on the tolvaptan therapy, we can troubleshoot this side effect by enhancing the hydration or reducing the tolvaptan dose temporarily to see the response till the problem is solved. Similarly, for the patients who are going to develop hyponatremia, we can reduce the hydration or increase the tolvaptan dose. And there can be initially 20% decline in EGFR. This is only because of hemodynamic effects of tolvaptan initially. So we should be careful that this early decline is not actually the progression of the disease itself. The most important side effect is tranexaminites, that is drug-induced liver injury, which was seen around in 5% of the patients in TEMPO 3 trial. Actually, Tempo 3 trial, they were assessing the LFTs at 4 monthly basis. So they actually unanticipated severe drug toxicity in around, I mean, 2 patients had to take off from the tolvaptan because of severe drug-induced tranexaminites. So the threshold to define tranexaminites is the elevation of ALT 3 times upper limit of normal with or without elevation of bilirubin 2 times upper limit of normal. If somebody on tolvaptan is going to have either of the two or both combined, immediately stop the tolvaptan. Look for the other etiology, like look for the infections, autoimmune workup, do a hepatobiliary imaging. If we find some alternative cause, try to mitigate the cause and restart the tolvaptan, maybe at this smaller dose, and then escalate weekly or monthly basis, which are allowed as per the studies. If somebody there we find there is no alternative cause and we are suspecting that it is drug related injury, actually, we have stopped the drug, wait for 7 to 10 days, see whether enzymes have improved. If enzymes have improved or return to the baseline, restart the tolvaptan at the lower dose. For example, somebody was a 90 and 30. We can begin with 45 and 15 and then slowly escalate to 60, 30 and 90, 30. And if liver enzymes are not going to elevate subsequently on follow-up, we can then escalate to the full dose. If on reintroducing the tolvaptan, somebody is again showing there is tranexaminites, we should permanently discontinue the tolvaptan and we should exclude such patients from the tolvaptan therapy. This is the most important question, although I don't feel this was very much related to the today's topic, but this is the most common question as clinician we will be facing in our clinic. The patient who has ADPKD will simply say, doctor, if I take a lot of water, is my this state of kidney going to halt? Can I stop the progression of worsening of ADPKD by alone taking a lot of water? So the answer comes from this study, which was published in NEJM in 2021. This was a good randomized controlled trial done over 3 years. They took the patients who had ADPKD and height adjusted total kidney volume as per the Mayo classification 1B and above. 1B is considered, actually, it's not considered to be a rapid progression, but to get a broader idea, they include the patients from 1B, 1C, 1D, and 1E, those who had eGFR of more than 30 ml. They divided the patients into two groups. One group received the prescribed water intake to reduce the 24-hour urinary osmolality to 270 and below. And the other group was allowed to take water intake ad libitum, irrespective of 24-hour urinary osmolality. So the primary endpoint was percentage annual change of the total kidney volume over the 3 years. We can see clearly there is not a significant difference between the two groups, the patients who had prescribed water intake or those who were given water, who took the water as ad libitum. Similarly, decline in eGFR was not statistically significant across the two groups. This does not answer the question that we should not prescribe the water. Definitely, by telling the patient to take a lot of water is going to, firstly, if he's on tolvaptan, it's going definitely to decrease the side effects of, he will avoid dehydration, he will have better compliance, he will keep himself hydrated. All the aqueous side effects will get minimized if he keeps himself with good hydration. Secondly, it has been seen, although there was not a statistical difference in eGFR and total kidney volume, but the excess water intake actually suppressed the vasopressin levels in these patients, which can be a driving force for the cyst growth. Although we need long-term and large sample studies actually to show the significant results with water intake in these patients. So my take-home message is that although tolvaptan therapy has shifted the paradigm of treatment from general measures to the targeted one and opened the horizon of new treatment modalities in such patients, but there is still a lot more to be done to cure the basic disease, and probably the gene therapy will have answer in future. With this, I would like to conclude my talk, and I thank you all for patient hearing and giving me an opportunity. Thank you very much.
Thank you.